OBGYN now for almost 30 years. This is my 19th year working with ExamPro, and I am a general OBGYN, like most of you are going to be. So I bring that experience to the perspective of the material and how it relates to the board exam, which is what we're focused on. So I'm going to give you a brief introduction to the course, just to cover a few things that will echo some of what Alvin said, but add a few additional details. So let me start with that. And while I'm doing that, I will just mention today, as we lecture, we are going to be using the slides that are in your high yield presentation manual. We'll be starting on page 179. The first slide is labeled Office. If you want to get that out so you can follow along and be able to make notes. So let me just say this. We're going to teach you very little about OBGYN this week. Medical school and residency did that job. Okay, you already have the fund of knowledge that you need to pass this exam. However, what you really have not been adequately prepared for is the format. Even if you've taken some oral exams, you probably haven't had much instruction on strategy, and you probably haven't had much feedback. And this course really aims to give you both of those. It is our top priority that by the end of this week, you'll understand not only the challenges, but also the opportunities presented by the oral exam. And a big part of your preparation should be focusing on high yield information and key concepts. And we aim to help provide you with that focus. So you will notice as we lecture, specifically the next 2 days, where we give you our didactic lectures, that we will not give you a grand rounds type of presentation on each topic. We will instead be focusing on specific concepts and facts. There are 2 reasons for this. First, in the exam, you will not be expected to deliver a grand rounds on a topic because there simply isn't time. And if you get lost in that kind of detailed presentation, the examiners will cut you off and it will not help you. So again, you're only going to get to spend a few minutes on any given topic, and we're going to try to help you focus on how to do that. Secondly, one of the biggest advantages of ExamPro's focused board prep course that you are currently taking is that we try to save you valuable time. If we were to give you a grand rounds on every topic, you'd be here for weeks, and you'd be less prepared because the amount of information would be more confusing rather than helpful. So just realize those kind of general concepts. I'm going to make a few other comments. First, this is an intensive preparation course for your oral board exam. The emphasis is on you managing your personal exam. I want to point something out about the oral exam. The oral exam is not the kind of exam where each question has only one correct answer. Your practice experience, your practice environment, your specific patient may lead you to give an answer to a question that's somewhat different than the person sitting next to you. And so just realize we're focused on helping you prepare for your exam. That's a very important point. You'll hear me say a couple of things like that in the next minute or two. The initial sessions, the office today, followed by gynecology, followed by obstetrics, these provide the essential information framework for your exam. And for the remainder of the course, we'll reinforce and practice this information in the oral board format. This is not an exhaustive information review. These sessions emphasize specifically high yield information and how you will use this information in your exam. So I will emphasize repeatedly how you will encounter these topics in the case list questions they ask you, because half of each hour will be case list generated questions, and in the structured case questions that they will ask you. And our faculty will do this through the week. So with that in mind, I want to mention a couple of other things. We find it's often beneficial if you have a copy of your case list in front of you while you take this course. And there are a couple of reasons for this. First, you might note how you can use some of this information for a particular case. You might make some notes on your case list to help you study later. You will have some idea of some of the questions that you might be asked about specific topics. So again, you might make some notes on your case list. You might identify, by listening to the lecture, a problem on your list, so you can make yourself a note about that. And really most important, to do well in this exam, you need to know your list. So this is a very good time as you're preparing to have it handy, and when something comes to mind, to look and see if it might be relevant to you. So having your case list present during this course could be very helpful to you. Now, a couple of other things, and then I'll get into the lecture. questions at the end of each session, and they're approximately 1 hour, 15-minute sessions. At the end of each session, I will have question time, question and answer, and all the faculty will during these didactic lectures. So if you have questions, just make a note. At the end, we will have question and answer. You can type them in and we'll answer them. The other thing that I want to mention is about other opportunities to answer specific questions during one other thing. When you have a question, please think about whether or not the question is relevant to the group. If it's a very specific question related to you and your case list, there are other formats that we can use to answer those questions during mock oral sessions or during evening practice or just by contacting us directly. So if it's a very specific question not relevant to the group, I ask you contact us outside of this lecture format. Okay, last thing, the lecture slides. Some of the slides that we'll present are intended for reference as you study, and we'll note this to you. So we're not going to read from the slides, and we're not going to necessarily comment on every piece of information on every slide, because some of that information is there for reference. It's high yield, but it's not going to necessarily be commented on, and we'll usually note this. The slides were finalized in March of 2023 so that we could publish the manual that we sent you. We have made some updates to certain information as it has changed even up until the end of last week. So the presenters will point things out to you if there has been a change that they are aware of. There won't be a lot of this, but it may happen. Just be aware that is why that would be the case. So I'm going to go ahead and let me just share my screen with you, and we will get into the lecture. Just going to get started here 1 second. Okay, so now we are on page 179, and we're going to start with the office lecture. And I'm going to just first mention to you that the very first slide, and hold on 1 second as I reorganize the way my screen is showing. Good. Okay. My apologies. It's all about technology, and I just want to make sure that we are working. Okay, good. The very first slide, chronic pelvic pain. I dare say I don't think I've ever met a candidate who didn't have chronic pelvic pain as part of their clinical experience and therefore part of their case list. So a couple of just overarching things to remember. We're talking about pain that's perceived to originate from the pelvis and last greater than 6 months. We have a better understanding than we used to, and there's a certain component of chronic pelvic pain that is central sensitization. This is chronic pain that's perpetuated by amplification due to abnormal processing of sensory information in the nervous system, okay? So that is a big part of chronic pelvic pain. And remember that chronic pelvic pain can originate from GYN sources or non-GYN sources. And so let's talk about this for a second. I'm going to go to this next slide. I'm going to show you 2 slides. And these 2 slides, I think, are important for a number of reasons. First, I want to mention that if you are asked for in the exam, they look at a case and they say, I want to ask you about your differential diagnosis for patient 26 with chronic pelvic pain. If you give the examiner 4 or 5 differential diagnoses, woefully inadequate. Because for chronic pelvic pain, you could probably easily come up with 20, 25, 30, and there's probably 50 things you could say if you were really, really trying to. I don't expect you to say 50. They won't give you that much time. So a question like your differential diagnosis for chronic pelvic pain in the oral exam presents a challenge. You want to get credit for being knowledgeable, but you also have limited time. The best way to handle this is, again, to remember GYN and non-GYN causes. And so I call this the high altitude approach. Start first by saying, well, in my differential, I would be thinking about gynecologic causes. That's what this slide shows you. I'm going to go forward for a second. And I'd be thinking about non-gynecologic causes like urologic, gastrointestinal, musculoskeletal, and psychological neurological causes of chronic pelvic pain. I'm going to go back for a second. Now I would begin, if they let me, to discuss my gynecologic causes. So in the gynecologic causes, I'm thinking about things like, and I would name as many of the different possible causes. We've kind of highlighted them for you by organ within the pelvis to give you an easy sort of structure to sort of remember some of these. And I would use as much time as they give me mentioning the differential diagnoses, keeping in mind, I want to mention the diagnoses that I was really entertaining with that particular patient. Okay, so that's the first thing I want to tell you about this is you can see how strategy can help you to make the most of the time that they give you. Now, a couple of other things. I want to point out MPPS. This is myofascial pelvic pain syndrome. You'll see it on this slide, and you'll also see it on the second slide because it comes up as potentially a contributing factor in multiple different compartments, if you will, okay? And let me just mention, patients with myofascial pelvic pain, they generally have pain in the pelvis, the vagina, the vulva, the rectum, the bladder, or in more distant referral areas, the thighs, the buttocks, the hips, or lower abdomen. They commonly have associated symptoms like aching, heaviness, burning in these areas. They may have symptoms of overactive bladder, constipation, dyspareunia, dyschezia. So this is one diagnosis that overlaps a lot of different symptoms and a lot of different potential mimics other potential organ system problems. So just keep myofascial pelvic pain in mind. I'm going to move ahead for a second because we're going to talk a little bit about the differential diagnosis. First, the most common diagnoses you're going to entertain or see with chronic pelvic pain tend to be endometriosis, adhesions, irritable bowel syndrome, and painful bladder syndrome. So just keep that in mind. And of course, during your exam, the workup will gradually evolve based upon your history, your physical exam findings, the initial tests you decide to order, et cetera. Don't forget to think about depression and anxiety certainly can contribute to chronic pain. With GYN evaluation, things that you might mention, HCG, obviously pregnancy-related issues, ultrasound for looking at anatomical issues, testing for infections, potentially a laparoscopy will come up in a case. It's not the first thing we do, but it may come up. And again, for the other organ systems, there are other tests that might be ordered. Now, I want to make a point here that's very important. I'm not recommending that you mention all of these tests for any given patient, because remember, your evaluation will evolve, it will narrow as you go through this process. So it's not, you might mention, I could order, if you were thinking about a GI problem, the patient to have some type of imaging, but you're not going to do that on every single patient. So again, it's not one size fits all in the oral exam. You want to tailor your response to your particular patient or to the particular question that they asked, but you do want to keep a broad approach in mind in the beginning that narrows as you go in these type of discussions when they come up. All right, just medical student stuff. When you're describing pain, PQRST, an easy way to remember some of the things that you're interested in. I already mentioned the multidisciplinary approach. Definitely want to keep that in mind. And I do want to say that before you do surgery on a patient, you always want to consider, should you involve one of your colleagues in one of these other specialties prior to surgery? Because if your surgery is a negative laparoscopy, maybe a third of all laparoscopies have no findings. If your next answer is, when they say, what are you going to do now? I'm going to send her to GI. Well, the question might be, why didn't you send her to GI first? Because if it's possibly a GI cause, maybe she didn't need the surgery. So again, keep these kind of things in mind as well. All right, so a couple of other chronic pelvic pain pearls. There are a number of different treatments that can be utilized depending upon what your presumptive diagnosis is. I think many of you are using pelvic floor physical therapy as well as cognitive behavioral therapy for these patients. I want to mention, when you have chronic pelvic pain associated with myofascial, with a dyspareunia, always be thinking about myofascial and or psychological components to that chronic pelvic pain. We really do not use opioids for chronic pelvic pain. So I would not recommend opioids as a treatment for chronic pelvic pain. And the routine use of laparoscopy for lysis of adhesions is not recommended. Now, let me explain what I mean here. So if you propose you did a laparoscopy simply to look for adhesions, that's not the best approach. If you did a diagnostic laparoscopy looking for causes of chronic pelvic pain, like endometriosis, and you discovered adhesions, and so you took those adhesions down, you lysed those adhesions, that's a very reasonable approach. So just the details matter a little bit. Getting on to hysterectomy. And I hope that some of you are like, hysterectomy for chronic pelvic pain, that seems a little extreme. And I would agree, it does. Remember that since hysterectomy is not our initial treatment for chronic pelvic pain, there's some defense of that decision that is required. So if you have often we see this, these are the younger patients on our case list that would have a hysterectomy. If you have a patient who had a hysterectomy and she's younger and it was for chronic pelvic pain, you need to be prepared to justify that. She had multiple visits over a long period of time. You had a very good relationship with her. You understood her situation. You understood her health history. You understood what problems she was having. That there wasn't an attention-seeking or secondary gain component that you could discern, and that you believe that her pelvic pain was GYN in origin. For instance, documented endometriosis refractory to other treatments, and that she would improve with surgery. So again, this is the kind of approach when you have a case that's a little bit more unusual or problematic. So I'm going to move on, and I'm going to talk for a few minutes. I'm going to talk about painful bladder syndrome. And hold on one second, because I want to do one thing here. Okay, sorry about that. So many of you may think of this as interstitial cystitis. The preferred term really is painful bladder syndrome, because cystitis implies inflammation, which is really not a part of painful bladder syndrome. And we're talking about here a chronic pain syndrome where there is some abdominal pain processing. Remember, I mentioned the sensory component of chronic pain. The pain can be suprapubic in the urethral area, in the lower abdomen or the back. The patients often will have report that they void frequently to avoid the bladder from filling, which can stimulate pain. The symptoms are worse when the bladder is full, and relief generally occurs when a patient voids. Painful bladder syndrome can coexist with other pain syndromes, including fibromyalgia or irritable bowel syndrome, so that can sometimes make it a little more difficult. When you do a post-void residual in a patient where you suspect painful bladder syndrome, remember, do it with an ultrasound estimate if you can, rather than a catheterization, because catheterization will generally provoke pain for these patients. The pelvic pain is a very common presenting complaint for these patients. They tend to have waxing and waning pain presentations, so their pain will be worse, then they'll have relief, then they'll get flares. So again, good, very important topic to have some working knowledge of. I want to mention that about 1/3 of the patients with chronic pelvic pain will have painful bladder syndrome. And I already talked about the fact that it coexists with other pain syndromes and the preferred terminology. Let's talk for a second about the diagnosis. It is a diagnosis of exclusion, okay? So really, we want to have the characteristic presentation. We've excluded other conditions to the best of our ability. We don't need to do a bunch of other testing. So for instance, cystoscopy with hydrodistension is not required. We don't generally do potassium sensitivity testing. We don't do lidocaine installation or any of these kind of things. Avoiding and fluid log to confirm frequent low volume voids can be helpful. Urinalysis with urine culture, looking for hematuria and infection also can be helpful. Post-void residual with ultrasound, again, looking to see that the patient doesn't have any other components of voiding dysfunction can be helpful. And then we move on to treatments. So I do want to mention that the big issue with treatment here is that there are a lot of different symptoms, and there are multiple different potential treatment options that can be utilized. And so the reason I say that is because when you look at this list, there are a lot of different things listed here, and I'm going to cover a few of these in a little bit more detail. I want to point out that amitriptyline is really first line. And this would be something like you start 10 milligrams a day, take it at night. You can increase it if you need to. And also, we always want to do behavioral therapy in combination with any medical or surgical therapy we do for a problem. In this particular case, things like avoiding excessive fluid intake, avoiding foods that might precipitate symptoms, sometimes caffeine, alcohol, peppers, artificial sweeteners have been associated with provoking these symptoms. And then, of course, we can get into things like pelvic floor physical therapy, if it's a component, or bladder installations for topical treatment. So let me take you through a few of these and make a few additional comments. First, Elmiron, which most of you are familiar with. So this is a potential option to amitriptyline. I do want to point out that there was an FDA warning issued in June of 2020, and the concern was regarding pigmentary maculopathy. This is a macular eye disease that develops potentially in some patients with long-term use. So just be aware that is a potential warning. Any patient who is going to go on this medication should at a minimum have a history of ocular health and also consideration for an ophthalmologic and retinal examination. And then it would not be unreasonable to also continue and perform a retinal examination every 6 months or so while the patient is on the medication, especially if they're on it long term. Now, I do want to also point out at the bottom of this slide a very important point. For patients who have painful bladder syndrome and a history of allergies, antihistamines is a very reasonable and proposed first-line medication to try. So remember, we see increased mast cells in bladder biopsies in patients with painful bladder syndrome. So antihistamines in those patients with a history of allergies can be a very good first-line medication. For instance, hydroxyzine, 25 milligrams to 50 milligrams at night. I talked about the fact that topical treatments can be used. Bladder installations, there are multiple ingredients that can be added to these preparations. Some include local anesthetics, and there also are some refractory cases where a specialist might use intradetrusor Botox or sacral neuromodulation. Now, am I expecting you to tell the examiners that you would do intradetrusor Botox? No. I want you to be aware of what some of the more advanced treatments would be, not necessarily how to provide them, but be aware of what they would be, because if you said at some point, I would refer this patient to urogyne or urology, it is a reasonable question that the examiner might ask you, well, why are you referring them? What's the benefit of that? You could say, well, I don't have experience with it, but I know there are a couple of other treatments such as that could, and you could mention these. So that's the bottom line. I do want to also mention the only FDA approved treatment is the Elmiron. So just be aware of that. All these other treatments are off label. It's always good to know when a treatment is FDA approved for that indication or off label. So please do be aware of that as well. All right, I'm going to move on. We're going to talk for a few minutes about persistent vulvar pain. So first, as this slide talks about, we can have vulvar pain with a specific cause due to trauma, infection, inflammation, neoplasia, hormonal changes. And then we can have vulvar pain where there is no identifiable cause. And that's what we talk about as vulvodynia. And ACOG has a committee opinion on this topic. I think it's number 673 off the top of my head from a few years ago. Just be aware, vulvodynia can be generalized or vulvodynia can be localized. I'm going to show you the next slide. This is just to make that point. Generalized vulvodynia throughout the vulvar area, localized vulvodynia in the vulvar vestibule, what we used to call vestibulodynia or vulvar vestibulitis back in the old days. Now we talk about as local vulvodynia. And chronic persistent vulvar pain can be characterized. It can be local or generalized. It can be provoked or spontaneous. It can be primary with no identifiable cause. Sometimes it can be secondary, incited by other disease processes that are not necessarily a cause of pain, but this may be associated with them. The timing and the pattern of the pain can vary. So it is a complex topic for that reason. When we evaluate patients, we want to be thinking about our history. Here are a slide that provides you with some examples of some of the things that we think about asking a patient with vulvar pain. And we want to be thinking about our physical examination. I want to point out that the Q-tip test that's mentioned here, this is using a cotton swab, testing, identifying the areas of pain and the degree or character of pain in that area. And then the musculoskeletal exam, also very important, thinking again about pelvic muscle overactivity or myofascial pelvic pain syndrome. So just keep that in mind as well, because it can present as vulvar pain. I mentioned that earlier. So vulvodynia is really a diagnosis of exclusion, sort of like painful bladder syndrome. And the treatment is usually multifactorial, starting with behavioral changes, things like eliminating triggers or vulvar hygiene, and then lubricants or pre-intercourse lidocaine, pelvic floor physical therapy, biofeedback. So again, this list of treatments, I'm sure you are familiar with these. In the exam, if you're asked about vulvar pain, you want to be thinking about where you're going to go with a particular patient and have some of these treatments ready to offer because, again, this topic relatively common in the exam, but not necessarily on everybody's case list. And so take a look at this if you're not as comfortable. I do want to mention that topical medications include TCA, estrogen, local anesthetics. Ointments are generally better than creams. There are less preservatives in the ointments than there are in the creams. Oral medications I already talked about. I want to re-emphasize amitriptyline as first-line therapy. I want to also re-emphasize a antihistamine in the patient who has a history of allergies. That could also potentially be something you could try in a patient like this, more with painful bladder syndrome, but can come up with vulvodynia. And then again, more advanced treatments that your specialist may offer. All right, we're going to talk for a few minutes about endometriosis. I feel pretty confident that most of you have more than one of these cases on your case list. They can be in the GYN section. They can also come up in the office section. The principal manifestation of endometriosis that we think about is chronic pelvic pain and infertility. And this slide gives you some of the background information regarding endometriosis, including something to think about, which is the theories of development of endometriosis. The most commonly proposed and accepted theory is that of retrograde menstruation, but realize it doesn't explain all cases of endometriosis. So there are some other theories that have been proposed. When we talk about treatments for endometriosis, we generally start with more conservative treatment and proceed to more aggressive treatment. I will mention non-steroidal anti-inflammatories are not listed on this slide, but they are a reasonable first option. There's not conclusive evidence of effectiveness, but for especially mild symptoms, this might be something that we try in the beginning. Oral contraceptives can be given cyclically or continuously, as this slide points out. We can use progesterone. We can use GnRH agonists and antagonists. And so I want to point that out. I'm sure most of you are very familiar with that possibility as well. If an initial therapy fails, we can try another empiric treatment. We might decide in some cases to proceed to laparoscopy, and we'll talk about that in a few minutes. All of these treatments are associated with recurrence once they are discontinued. So do keep that in mind. That is one of the challenges, as you are aware, of endometriosis. It's also one of the reasons we want to be as conservative as we can and work to find something that is effective rather than jumping to the most aggressive treatment, which may have the most risks and complications. We'll talk about that in a second. So some of the management options, just to give you some idea of how you might present this in the exam. If a patient has mild to moderate pain on their evaluation, their ultrasound does not demonstrate an endometrioma, then we really do start with these conservative things like non-steroidal anti-inflammatories, OCPs, progestins, reassess in 3 to 4 months. This is not something we're going to see the effect in 1 to 2 weeks. We need to give them an adequate trial of therapy. That is a very important point in the exam. When you give somebody therapy, what is an adequate trial? And for different treatments, there are different lengths of time. When you follow somebody up, specifically like with imaging or lab testing, what is the appropriate period of time? And most of us are very comfortable with this. We're doing this kind of stuff every day, but these are some of the key points you want to brush up on if you have any doubt. So in this case, we're talking about 3 to 4 months. If there's no improvement, again, we often try another empiric conservative therapy. If we see a patient who's not responding, then we can think about a GnRH analog, which would be like a GnRH agonist, or we can think about a GnRH antagonist, and these therapies can be employed with add-back therapy, or we can do surgical evaluation and treatment. And there are certain situations in which that would be helpful. I'm going to move to this slide. So if you are asked about your surgical evaluation and treatment of a patient with endometriosis, you want to make sure and discuss your initial evaluation, at least briefly. You want to confirm that the history and physical were consistent with endometriosis. You had excluded, to the best of your ability, non-gynecologic etiologies of pain. And preferably prior to surgery, the patient had a failure of a trial of medical therapy. Now, I will say, as this slide points out, fertility does give you a good reason to bypass a trial of medical therapy. If the patient you have a strong suspicion of endometriosis and fertility is a big part of her presenting problem, these medical suppressive therapies, they're not effective for fertility. So this would be potentially a reason to consider moving more rapidly towards surgical evaluation and treatment. I also want to point out that an asymptomatic endometrioma that is 5 centimeters or less does not really justify surgical evaluation for the reason of infertility. Because when you look at this, small endometriomas that are asymptomatic, they're not proven to interfere with fertility, and surgery to remove them can remove some of the normal ovarian tissue, and that can cause a reduction in ovarian reserve just by the fact that you did that surgical removal of some normal ovarian tissue. So again, endometriomas, there are some things to think about as to whether or not they are, and I mentioned asymptomatic, as to whether or not they are a justification for taking a patient to surgery. Let's talk for just a few seconds about hysterectomy for endometriosis. So when you have a patient who has been refractory to other treatments, she has no other explanation for the pain, the diagnosis of endometriosis has been established, especially if it's been biopsy proven, that always helps. Then definitive treatment has always been hysterectomy with BSO. I will say that BSO is not required. In women with normal appearing ovaries, we might do a hysterectomy, and in fact, we would often do a hysterectomy and a bilateral salpingectomy for ovarian cancer risk reduction and leave one or both ovaries behind. And this is a very reasonable approach if you are doing a hysterectomy for endometriosis. These patients tend to be younger, so you may want to be thinking about, and this is again a high yield point, thinking about optimizing the treatment and minimizing the risk for a particular patient. If you do remove the ovaries, you can give estrogen therapy, estrogen replacement therapy, since symptoms of endometriosis have been shown that they recur with or without estrogen replacement therapy, so it's not a contraindication. All right, ACOG has a committee opinion from 2018 that talks about endometriosis in the adolescent. And I just wanted to point out a few key concepts from that. First of all, most adolescents who present with dysmenorrhea, they present with primary dysmenorrhea, and that's not going to necessarily be related to endometriosis. But when we think about secondary dysmenorrhea, then this is going to be the situation where endometriosis is quite common. About 2/3 of adolescents with secondary dysmenorrhea have endometriosis associated with that. Most respond well to empiric treatment. So we want to think about the use of empiric treatment as our first line approach. If a diagnostic laparoscopy is performed, which will happen with some patients who don't respond, who have significant symptoms and a strong suspicion, if you do a diagnostic laparoscopy, consider placing a levonorgestrel intrauterine device in the OR, because this will be you'll be able to place it and minimize the pain of insertion for these younger patients, generally who have no children. So again, it's another treatment modality, and an ideal way to institute it. Keep that in mind. All right, I'm going to move on from endometriosis. I'm going to take you through some highlights of preventative care. I first want to start by mentioning that preventative care, think screen, evaluate, counsel, and immunize. It's a very nice way, screen, evaluate, counsel, and immunize, to think about preventative care. Many of the things that we do in preventative care arise related to three key factors: the age of the patient, the gender of the patient, and risk factors that the patient has for a particular condition. When we think about examples of this, vaccination, absolutely. We could think about, for instance, just if we pick a vaccine, say HPV vaccine, definitely an age component to that. It is applicable for all genders, so that's not a relevant issue there. And it is applicable for patients who have risk factors. But again, with any given screening or preventative care issue, you will have some age, gender, or risk factor relationships that apply. Cancer screening protocols are the same way, and I'm going to take you through some of the more important ones for the oral exam in the next few minutes. You will almost certainly, because I rarely see a case list that doesn't have a preventative care case in that category, because there's a category for preventive care. So you almost certainly have one or two of these cases on your list. And when you are thinking about how your age appropriate physical exam, history, screening, counseling, here's a few things to think about that you may want to incorporate in that discussion. Some historical things. Certainly we want to be thinking about stress, about diet and exercise, sexual function, intimate partner violence, substance abuse, symptoms depending on the age of the patient related to urinary, menopausal, or fertility issues, depression screening. Not hard, a lot of nice things you could volunteer to the examiner that you routinely cover in your history during your preventative exams. Physical examination, it's not going to be the same for every patient. I would not advocate that I'm going to do Tanner staging very often, but there will be some cases where I might volunteer that, particularly if you have pediatric gynecology patients on your list. Be more aware, be more prepared for that. Pelvic exams. I'm not going to do an internal pelvic exam on every single patient. And I'm relatively unlikely to do a rectal exam on an asymptomatic, healthy patient, but there are some cases where I might. So again, the physical exam, it's not one size fits all. It's good to be comfortable with the things that you generally are going to do routinely and the things that you might do and when you might do them. With labs, again, we'll talk about a few routine screening labs on the next slide, but it does depend a little bit on the age of the patient and the H&P. And then this age-appropriate counseling. I love when I see on a case list age-appropriate counseling, and I really love it when the first patient is 20 and the second patient is 70. But even if you put two 20-year-olds, the examiner may simply say, well, if this patient was 70 instead of 20, how would your age-appropriate counseling be different? And many of the things that we counsel for are similar across age groups, but many of them also are different. So keep that in mind, especially if you've said age-appropriate counseling, and be able to talk about a few of the key things that are most important for that particular patient. And here's a list that we've given you, some of the key things to think about. I do want to mention, even in a patient who does not have an infertility complaint, we should be thinking about family planning, future fertility desires in all of our preventative care of reproductive age women. So keep that in mind. And I will also mention that one of the best times to incorporate preconception counseling, if you can do it, is in your pre-pregnancy preventative care. So it's another discussion you could introduce into the exam by simply saying something like, well, for this patient, I would also have done some preconception counseling. What's the next question that the examiner is likely going to ask? Well, what preconception counseling are you talking about? So if you do it on purpose, this is, we'll talk later this week about strategy and introducing topics that are important to you that you want to talk about. That's one of the ways you could do it. So let's continue. This is a list of some routine screening lab tests and when they would normally be recommended. And of course, not every patient is going to need a battery of lab tests. And so that's another thing to keep in mind. There is some judgment in this exam regarding your utilization of resources. So if you are somebody who routinely orders a large number of unindicated labs on every patient, that will look unfavorably upon you. So again, most of the time there are some appropriate labs and we've listed them here. I do want to remind you that screening for gonorrhea and chlamydia would be indicated and should be done for all patients under the age of 25. And I want to remind you that when one of those tests comes back positive, we should recommend or offer to that patient a full STI panel. So keep that in mind. Hepatitis C, a little bit more important. We're seeing more of that. So I think that is a topic that is a little bit more likely to come up in the exam. It is recommended that all patients, all adult patients, be screened once in their lifetime. And of course, if a patient had risk factors, just like with HIV, we would screen them more frequently. Screening for osteoporosis, we'll talk a little bit about that later in today's lectures. So I am going to talk for a second about substance abuse, specifically alcohol and tobacco. These are two topics that are too high yield not to spend a couple seconds on. There are several different alcohol screening tests that can be used, audit, CAGE, TACE. TACE is validated for use in pregnancy, so it's one that I like to use because I can incorporate it into a discussion in pregnant patients as well. Remember that unhealthy alcohol use in women is greater than 7 drinks in a week or greater than 3 drinks on any given day, and I'll talk about that in the next slide. The reason that this topic is so critical for your oral boards is that many of us are a particular patient's only physician. The OBGYN often by default for younger patients may be their primary care physician, especially if they don't have any other medical problems. And so this topic is part of their general health. It's a common concern, common problem across society. So be prepared. Also, when I talk about a screening system like TACE, you should also be comfortable to discuss how you would score that. Now, I want to go on and just mention, again, for women at risk or unhealthy use, greater than 7 drinks in a week, greater than 3 drinks on any given day. What qualifies as a drink? Well, it depends on what alcohol product we're talking about. Generally 12 ounces for a beer, 5 ounces for wine, 1.5 ounce for liquor. And this is based upon the relative alcohol content in each of those drinks. The overuse of alcohol has significant risks, and we've listed a bunch of them here. There are many different things you can say, which makes it pretty easy. Smoking cessation, like alcohol, important for many of the same reasons. There are a lot of different risks from smoking. It is something where anytime we encounter a patient who uses tobacco, we should look for an opportunity to encourage her to quit. We are fortunate because some of the things that we are doing are, for instance, prenatal care, are natural opportunities to talk about smoking cessation, and they have secondary gain for the patient. So for instance, a patient who's pregnant will be a little bit more concerned because she's worried about the health of her fetus and her children. So this can sometimes be a motivator for patients to be more interested in quitting. A patient who's going to undergo surgery, if she understands that smoking cessation prior to surgery, even if only for a few weeks prior to surgery, can potentially lower her risk of complications, that may be a motivator for her. So have some method that you use for encouraging smoking cessation, for assessing patients. The 5 A's approach is a very nice approach: asking, advising, and when we advise, we ask patients to quit, not to cut down. Okay, it's been shown that when doctors ask patients to quit, they get a lot more traction than family members, ministers, colleagues. So when doctors ask, patients do take it a little more seriously. Again, we ask them to quit, advise them to quit, assessing their willingness, and then assisting them to get started and arranging follow-up. All right, excuse me 1 second. Pill to sneeze coming on, sorry about that. Okay, we're going to talk for a few minutes about cervical cancer screening. This is something I think is probably going to be pretty routine, but there are also a few anxiety points about it in regards to discussing it in the oral exam. So let's go through this. The first slide is the screening protocol that I believe you guys will be using. And it goes by age on the left, the interval and type of screening that would be appropriate. and any qualifiers that are related to this. So this should be pretty much easy review for you. The next slide, what about special populations? So for pregnant patients, the key thing, no endocervical curettage during a cervical cancer evaluation, excisional biopsy or repeat biopsy only when we're thinking about invasive cancer. Generally speaking, for abnormal results, we're going to do colposcopy every trimester or defer it to the postpartum period. If we do postpartum follow-up, we want to do it no earlier than 4 weeks to give the patient a time to heal from the delivery process. For immunosuppressed or HIV positive patients, so this slide, I will mention that there is growing evidence and sort of advocacy for not starting to screen before age 21 in these HIV positive patients, okay? When we do start, and that's because the risk of cervical cancer before age 21 is effectively almost zero. So again, rather than starting the initiation of sexual activity within a year of that, more and more the recommendation is start at age 21. When we do start screening these patients, we start with cytology only, and the first 3 screens are done annually. And then if they're all negative, we would repeat screening every 3 years. For patients who reach the age of 30 or greater, we would do co-testing. And if it's negative, we would repeat the co-testing every 3 years rather than every 5 years, like for a regular patient. And we would screen for life. We don't stop at age 65 like we would in other patients. What about patients who had a hysterectomy for treatment of cervical dysplasia or AIS? These patients will get annual screening for 3 years following that, and then they'll get screening every 3 years for 25 years post-treatment. What about after a patient gets the HPV vaccine? This should be a no-brainer. I believe all of you are up on this 100%. It does not change our screening approach. HPV vaccine, very important. We recommend it. It doesn't change our cervical cancer screening approach. You should be familiar with the Bethesda system terminology that would be reported in the cytologic component of your cervical cancer screening results. A couple of general concepts about cervical cancer screening. There is an age-related component to how we deal with cervical cancer screening and cervical cancer screening results. Remember, 80 to 90% of young patients will clear HPV infection within 2 to 5 years. And when we think about persistence of HPV, we're generally talking about persistence beyond 6 to 12 months. If we have a young patient, she's more likely to clear it rather than to develop worse problems. There is on the converse, there's a predisposition for pre-malignant disease in older patients. So again, younger patients more likely to clear, older patients maybe a little bit more likely to have persistence and develop cervical dysplasia. Treatment can affect future pregnancy risk, particularly when we talk about excisional procedures and the risk for cervical weakening and premature delivery. So again, this is another reason if a patient, by virtue of being younger, is lower risk, we don't want to be overly aggressive in our evaluation and treatment. I do want to point out that LSIL or CIN1 is typically not considered a precancer, except in the older patient with persistent abnormal results. CIN2 is something that goes both ways. It can regress or progress. And CIN3 and AIS are both definitively considered precancerous conditions for which we would usually institute some type of treatment plan. Regression rate for CIN1, 60% or more. For CIN2, about 40 to 50%. So just keep that in mind. So HPV infection is common in sexually active adults. Healthy people do usually clear the virus. It's usually a transient infection in comparison to some other infections like HSV, which are lifelong. Persistent infection over a prolonged period of months or years with high-risk HPV types, of which we've listed many of them here, is really what we believe is required to develop cervical cancer. Smoking is associated with increased risk for squamous cell carcinoma, but not so much, it's not really associated with adenocarcinoma of the cervix. On average, this is a slowly progressing condition. 3 to 7 years to go from CIN3 to cancer, approximately 15 years to go from initial HPV acquisition to invasive cancer. This is comforting for us because it gives us a window of time in which to assess patients, make the diagnosis, and treat them to prevent cancer. But it also is important to keep patients on a regular screening protocol so that they don't fall outside of the normal window and end up with a prolonged period with no surveillance where their risk potentially is increased because of the timeline that's involved here. So I'm just going to move on from that. I'm going to make a very important point with this slide. And I know we're covering a lot of information, and I apologize, but I think you'll see when you get to the end of this, these high yield points are presented in a way that you'll be able to integrate them into your oral exam. This point, colposcopy is not as sensitive as we used to think. We used to say that a physician could likely look at a colposcopic exam and make the diagnosis, but studies showed that's not true. And so for that reason, if you see a lesion, you should biopsy it. What about doing an ECC? When is that indicated? Well, if you see no identifiable lesions on the ectocervix, you should evaluate the endocervix. If your colposcopy is unsatisfactory, that brings up a question to be prepared for. How would you define a satisfactory colposcopy? So if you're not comfortable answering that, I warned you, okay? If you're considering ablative therapy with cryo or laser, which is still appropriate, if you're considering doing that, you should evaluate the canal first. And if your PAP shows a very severe condition, ASCH, HSIL, atypical glandular cells, AIS, then you should definitely consider doing an ECC. Remember, not in pregnancy. And one other thing, if you're planning on doing an ablative procedure, cryo or laser, and your ECC that you did comes back positive, you want to change your plan. You want to do an excisional procedure because the ablative procedures, those superficial procedures, are not going to get deep enough to treat the canal. So it's an important reason why you want to do that ECC in those cases. What about endometrial cells on a pap smear? If it's a premenopausal patient, no further evaluation. If it's a postmenopausal patient, endometrial sampling. If they're atypical, think about evaluating the endocervix as well as the endometrium. And if you get nothing, think about colposcopy and looking not only at the cervix, but also potentially at the vagina. So this is one of the, I think, more anxiety-provoking parts of the cervical cancer screening discussion, and that is the ASCCP app and deciding what to do with the results, okay? So the first thing I want to say is I hope to relax you a little bit by simply saying that the examiners, they use the app as well, and none of them are going to be able to generate every result from memory. That's why they use the app. So you're not alone there. So it's an unreasonable expectation for me to give you a de novo result off the top of my head and you to calculate it in your head without the app. Okay. So if that's your biggest fear of this topic, don't be afraid of that. That is very unlikely. If they ask you something like that, they are messing with you and they know you're not going to be able to answer that question. However, there are a few things that you do need to remember about the background behind the app, okay? And these are things they would expect you to be able to discuss if you're in a discussion of a patient on this topic. So a couple of these key points, let's go through them. First, management is based on present risk of CIN3 or higher, rather than on the individual cytology and HPV result. And if you use the calculator on a regular basis, which I suspect you do, you know that it has the opportunity to enter past results. So it's not just based on one result, it's based on the patient's overall assessment of risk for CIN3 or greater. And that's for management. Surveillance is then, once we conclude management, is often based on the 5-year risk. So that's a secondary component, but not the key point that I want to really focus you on. Next point, any HPV positive result, if it did not have cytology with it, should have reflex cytology. So if you're doing HPV alone, get an abnormal result, you should have reflex cytology. For HSIL, CIN2 or 3 or AIS, treatment with excision is generally preferred over ablation. For CIN1, observation is preferred over treatment. HPV 16 or 18 positive results have the highest risk. I would expect you to know that. Colposcopy or biopsy is required prior to treatment, regardless of the cytology result, to evaluate for invasive disease. So colposcopy or biopsy, not colposcopy and biopsy. And I want to make sure I don't confuse you there. If you get a patient with HSIL who's HPV 16 positive, her level of risk is 60% for having CIN3 or greater. And so you could and probably should proceed straight to an excisional procedure rather than a colposcopy. So an excisional procedure is a biopsy. So you might not always do colposcopy, because if colposcopy won't change your management, and in that case, HPV 16 positive with HSIL, a normal colposcopy would not reassure you. So it wouldn't change your management. So in that case, proceeding to a biopsy would be reasonable. So again, the point I'm making is a colposcopy is not always required. And the way we decide is based upon risk stratification. Patients who have a 25 to 59% risk of CIN3, colposcopy is an option. Biopsy could also be done without colposcopy. Patients greater than 60% or greater, excisional biopsy would be preferred. Colposcopy is not necessary. And patients under 25%, we're going to start with colposcopy if they need evaluation. So I expanded that discussion a tiny bit, but the point is to realize that colposcopy is not always required. And then after treatment for HSIL, CIN2, CIN3, or AIS, surveillance at 3-year intervals for at least 25 years once they finish the initial monitoring period. And this can be done with HPV testing or co-testing. So these are some of the key points in the current sort of management of cervical cancer screening results. Now, when we're treating CIN, ablation versus excision, I've made a couple of comments about this. I'm just going to briefly say they're both equally efficacious. There is a general preference for excision if the concern is greater, because it provides a specimen for pathologic evaluation. And so we have a list of some of the factors that might tilt you more towards excision. And so take a look at that. When we talk about excision, as you guys all know, we're talking about cone or possibly a LEEP. And there are some situations in which we would prefer a cone. Really, they give us the same information, but the difference has to do with the ease in acquiring larger, more extensive specimens, and specifically in the evaluation of the cut surface of the biopsy, which of course is more difficult with a LEEP because of the cautery effect, okay? So here are some considerations when a cone would potentially be a better choice. Now, I want to point something out. If you have done a LEEP for one of these situations, this is not a problem so much as an opportunity. If you recognize things in your case list where you manage something in a way that could be controversial, it is a gold mine. It's a gold mine because the examiner is likely to ask you about it. And if that's not a problem, if you are aware of it before you go to Dallas, so that you can think about it and make some comments about why you chose to do what you did. And I think that is a very important part of what we're going to teach you this week, is strategically answering questions where you made choices that have multiple different possible options. Okay. This just puts LEEP versus cone into a chart. I'm not going to read it to you. I think you are aware of some of the advantages and disadvantages. I will point out a cone really can't be done in the office. So that is one big advantage of a LEEP. What about management of positive margins on a LEEP or a cone done for CIN2 to 3? So positive margins do indicate a higher risk for residual or recurrent disease. You should be thinking that. And because of that, we want to be very diligent about our follow-up testing. We usually will use HPV testing in 6 months. And if that's negative, of course, annually for 3 years. And then because this is a high-risk condition, they're going to be followed for every 3 years for 25 years from that time of treatment. If an HPV positive result comes back during this post-surveillance, post-excisional biopsy surveillance, then of course we're going to do colpo and biopsies again and evaluate. You can do colposcopy and ECC at that 6-month follow-up, and that's reasonable and acceptable if you choose to do it. Re-excision is acceptable for patients who are greater than 25 with no future fertility concerns. So you get a positive margin on your LEEP or your cone, re-excision is an option. It's not really required in most cases because the cautery that we do at the conclusion of an excisional biopsy, either LEEP or cone, we usually cauterize the bed. This will destroy 1 to 2 millimeters of residual tissue. Oftentimes the positive margin, if it was positive on the bed, it will be destroyed by that cautery, which is why repeat excision is an option for patients older than 25, not desiring future fertility, but it's not required. Many times their post-treatment follow-up from the original excision will return reassuring results. And I know you're aware of this. I just want to emphasize that point. Okay, what about I do a cone or a LEEP and I take the patient for a hysterectomy, even though she had positive margins. So this is a problem. It's also the same thing if I do a colposcopic biopsy and I get HSIL and I take her for a hysterectomy without doing an excisional procedure like a LEEP or a cone. The problem is any incompletely evaluated and treated cervical dysplasia that goes for hysterectomy may end up that the patient has cervical cancer on her hysterectomy pathology. And there was a study years ago that looked at this. And what they found was about 8% of those patients had a cervical cancer. So if you have a patient on your case list who had a LEEP or a cone, had a positive margin, and the next step you did was a hysterectomy, you will be asked about the staging of cervical cancer probably, and you'll probably be asked about the treatment of cervical cancer by stage, understanding that a simple hysterectomy is not the treatment for all stages of cervical cancer. So this is, again, an opportunity. If you have something like this on your list, you identify it and you prepare and you can talk about it. Many times when I see these cases and I ask people about them, they give me this one answer. They say, well, the patient refused the repeat excision or the follow-up. She insisted on a hysterectomy. Now, that's possible, but most patients are reasonable people. And if you tell them that they could have a cancer, they will generally want to get that evaluated and have the right treatment. So I would hope to hear, well, I talked to her about the risk. I even offered her a referral to GYN Oncology for a second opinion, or to a partner of mine for a second opinion. Whenever you have something where a patient is refusing important and appropriate therapy, always consider the discussion of a second opinion, because there may be a communication issue going on that you're not aware of. So again, how you present the case can have some sway on how it is judged in the exam. And the most important thing is going to be your knowledge of basic cervical cancer staging and treatment, if you have one of those cases on your list. Because if you're oblivious to the staging and management of cervical cancer, then I think, as an examiner, I would think you're oblivious to this risk. Okay, so I think I made my point. I'm going to move on. When is hysterectomy appropriate for CIN 2 to 3 that has not been completely removed? Well, generally, it's the one get out of jail free card is when the cervix was too small to recone, so you needed to do a hysterectomy. Now, I'll say, if your cervix is so small that you can't do a cone, and your anatomy is so distorted, and then you tell me you did a TVH, I'm going to think, interesting. You had good enough anatomy to do a TVH, but not good enough anatomy to do a cone. I'm not going to say that that's never the case, but that would strike me as unusual. So again, look at your cases carefully and think about the different issues that are in play. All right. Management of AIS, much less common than CIS. AIS has a few unique concerns. First, it's associated with skip lesions. That does not mean that there will always be skip lesions, but there can be skip lesions, multifocal disease. It frequently extends further into the endocervical canal. When you have negative margins on a excisional procedure for AIS, it is reassuring, but not as reassuring, because you might have a lesion higher up. And that's really the issue that makes AIS so difficult for us to manage. So hysterectomy is really the treatment of choice for AIS in women who have completed childbearing. And that's despite the fact that in most of those cases, the excisional procedure was curative. I do want to mention, again, cold knife cone is the preferred excisional procedure for AIS because of the greater depth and width that is generally removed compared to a LEEP, and the fact that the margins are easier to interpret. All right. It is potentially possible, by the way, for surveillance in a case of AIS for a patient who desires future fertility. I think the surveillance is less accurate than for CIS. And so for that reason, the counseling is very specific. And it's also another situation where involvement with a GYN oncologist for a second opinion can sometimes be helpful if you have that available to your patient. So I have spent a considerable amount of time talking about cervical cancer screening and management of results. I am going to move on and talk about some other primary care screenings that you should be comfortable with. First, colon cancer screening. It is now recommended that we start colon cancer screening in all individuals at age 45. In higher risk individuals, we should consider starting earlier, generally 10 years earlier than their previously family member diagnosed age. When we get to age 76, there should be some shared decision-making about whether to continue screening. And that's a topic of many screening tests in older patients, discussing their life expectancy, their current health status, the likelihood of them pursuing further evaluation and treatment if the screen came back abnormal. And then generally speaking, at age 85, we're not going to do colon cancer screening. There are many screening options. No single option is preferable to any other option. The deciding factor is really what the patient will and can access. So I always like to see patients get colonoscopies. They do have the greatest reduction in mortality from colon cancer. So when we look at a screening test, there's statistical data about how much it reduces the risk of dying from that disease if it's employed according to schedule. Colonoscopy has the greatest risk reduction, about 80% reduction in mortality from colon cancer. But if a patient can't or won't get one, it's not going to help. And so for that reason, any of these different methods are reasonable. I do want to point out, annual fecal blood cards must be on 3 different stool samples. FIT is fecal immunochemical testing. It is generally done on, done annually on 1 stool sample. Cologuard is a multi-target stool DNA test. It looks at hemoglobin in the stool and DNA mutations and methylation. And this is generally done every 3 years. And then you have capsule colonoscopy, if you will. And this is something that can be done every 5 years. This one is considered a lesser desirable method of testing, still somewhat investigational. So these are the options. Any of them are acceptable. You should be aware of what you would recommend to a patient, what you would offer to a patient for colon cancer screening. Just a couple of comments. Breast cancer screening, we talk about annual screening beginning at age 40. That's ACOG's recommendation. There are recommendations from other organizations that differ from this. The argument about the different recommendations has to do with the very low prevalence of breast cancer in patients in their 40s, which means a much larger number of patients have to be screened to prevent 1 death from breast cancer. However, for any patient in her 40s diagnosed with breast cancer who's been treated, they'll tell you they're happy they were screened. ACOG tends to side with the patient on this issue rather than on the cost of screening, but that's what the argument is among the different recommendations. Lung cancer screening. It is recommended an annual low-dose chest CT scan for lung cancer screening for patients 50 to 80 years old who have at least a 20-pack year history of smoking and they quit less than 15 years ago. Very, very important to know about this, even though you may or may not be doing it, but it could come up in a discussion of smoking cessation counseling, particularly in an older patient who smoked for a long period of time, if you were to get into that discussion. Ovarian and endometrial cancer screening, no recommendations for routine screening beyond detailed family and personal cancer histories, okay? So cancer history is very important for identifying high-risk individuals who may have interventions that are appropriate, but for low-risk individuals, we are not doing routine ovarian or endometrial cancer screening. I'm just going to run through these couple slides on BRCA pretty quickly. You can order multi-gene panels to assess for other mutations besides BRCA when you identify a patient to be screened, and there are commercial tests that are available to do this, like the Myriad MyRisk test, which a lot of people are familiar with. Who should we screen? That is a question you should be prepared to answer. And these high-risk individuals based on family history or ethnic background would be who we would screen. There are a lot of different ways you can discuss who should be screened. I would be able to talk about a couple of these if you were asked in the exam, and in particular, if you have BRCA patients on your case list, which many people do. Remember, it's autosomal dominant inheritance. 25% of hereditary breast and ovarian cancers are due to mutations other than BRCA1 and 2. So BRCA1 and 2 is the discussion I anticipate most likely, but it's not the only genetic cause for inherited breast and ovarian cancer. The last bullet point on this slide, talking about the percentage association with breast and ovarian cancers. The main point is that if you're diagnosed with ovarian cancer, you're more likely to be BRCA positive than if you're diagnosed with breast cancer. That's how I would sum that up. Patients with BRCA mutations develop disease at an earlier age than sporadic cancers. When we have a patient who's BRCA1 or 2 positive, we do enhanced screening for breast cancer, and we can also do chemoprophylaxis with tamoxifen, so we should be familiar with that. That is specifically for patients who are BRCA2 positive. It has not been shown to reduce the risk for BRCA1, and of course, we refer them for surgical risk reduction. I'll talk in a second about ovarian. Actually, I'm not sure if it's on the slide. I will mention ovarian cancer. Of course, we have the risk-reducing surgical options for a risk-reducing BSO, and this would be considered for patients with BRCA1 a little bit earlier than patients with BRCA2. So generally age 35 to 40 for patients with BRCA1, age 40 to 45 for patients with BRCA2. For patients who are not to that point yet, we can use oral contraceptive pills as a risk reduction technique for ovarian cancer. Routine screening for ovarian cancer with transvaginal ultrasound and CA-125 has not been shown to be helpful. Okay, I want to just mention these statistics. You should know these. The risk of breast and ovarian cancer related to whether you have BRCA1 or BRCA2. Of course, breast cancer risk is the same for both. It's ovarian cancer risk that differs. It's a little bit greater with BRCA1. And some of these other cancers that are associated that we've listed on here would be also appropriate to know. Mucinous and borderline ovarian tumors are not part of the BRCA tumor spectrum, so also keep that in mind. All right, let me look at where we are at on time because I want to make sure that we stay on schedule. And so we are scheduled to go to Q&A in about 5 minutes. So I'm going to go ahead and keep going, and then we'll go to Q&A there in just a couple minutes. So vaccinations, also a very high yield primary and preventative care topic in the exam. We've given you this table which lists the key vaccinations that you should be aware of as an OBGYN. I want to mention to you a couple of sort of high yield ones. First of all, COVID-19, which you're all familiar with, because we've been dealing with this for the past few years. It's been sort of the flavor of the day. I want to go to this second slide, and I'm not going to go through all the different details, but I will tell you with COVID-19, remember, mRNA vaccines are preferred. You should have at least if you offer or recommend one, be aware of the dosing schedule. And it can be given simultaneously with other vaccines. So that's another important point. Okay, I want to talk for a second about a couple of vaccines on this page. First, a lot of OBGYNs are not giving a large number of vaccines in their office. They may be giving none. They may be giving HPV. Potentially, they're giving Tdap because of our pregnant patients. But there are a lot of vaccines that they may not be giving. And so I do want to point out that the pneumococcal vaccination strategy which is targeted towards older adults, 65 and older. This is something that has changed over the years. So the current recommendation for pneumococcal vaccination is the Prevnar 20 vaccine. So I just want to point that out. So it's an easy thing because it's just one vaccine. There are a couple of, in the past, there was a period of time we were giving 2 vaccines separated by a year. And before that, we were giving the Pneumovax, which is the PPSV 13, if I remember that correctly. So again, the current strategy is Prevnar 20, and that's the preferred approach. I do want to also mention that Gardasil, very, very high yield. That's the HPV vaccine, of course. The only vaccine available now is the non-valent, the 9-valent Gardasil. So that's what you would be giving. If there is a dosing schedule for patients who are under 15 when they get their first dose. They only need 2 doses. Patients that get their first dose at age 15 or older need 3 doses. So that's important to be aware of. It is, if a patient previously was vaccinated with the quadrivalent Gardasil, it's not recommended that they get revaccinated with the non-valent Gardasil. It is indicated for boys and girls, men and women between the ages of 9 to 26, with the extended indication for patients that are 27 to 45. Okay, the benefit of vaccinating 27 to 45-year-olds is somewhat reduced because these patients are more likely to have previous exposure to the HPV virus. So that does somewhat diminish the effectiveness of that vaccine. All right. Well, by the way, if you were asked in the exam what high-risk HPV types are in the non-valent Gardasil, and you were struggling to remember it, I'll just give you this little potential strategy. I think it's completely reasonable if you said, well, it includes 6 and 11, 16 and 18. Those were the ones that were in the original Gardasil. And 6 and 11, of course, are low risk for genital warts. 16 and 18 are high risk for cervical cancer. And then 5 other oncogenic HPV types. And if you gave that answer, they're not going to say, good job. But trust me, it's more than adequate. Okay. And it would look better than if you didn't have the other high risk types memorized. So you volunteered some numbers and they were incorrect. Okay. So again, a strategy, if you get into that situation, you can't remember the numbers. 6 and 11, low risk for genital warts, 16, 18, high risk for cervical cancer, and 5 other oncogenic types. Okay. There are some primary care topics that are common enough in OBGYN that they are likely in the oral board exam, even if you are in a traditional OBGYN practice that doesn't do a lot of primary care. And sometimes we list cases on our case list that have to do with a particular topic, trying to broaden our sort of presentation so that we look like, we're very comprehensive, when in reality, we would have referred that patient to primary care the moment we got the result back. So with that in mind, cholesterol is one of these, and there are a few key points I want you to know about cholesterol. You should know what the components are of a standard lipid panel. They are listed here: total cholesterol, LDL, HDL, etc. You should know what the normal cutoff is, and that's listed here as well. And you should realize that cholesterol is just one of several risk factors for cardiovascular disease. The baseline issue here, I'm going to advance a slide for a second, is cardiovascular disease in women. It's the leading cause of death worldwide for women. In addition to traditional risk factors, there are some female-specific risk factors: adverse pregnancy outcomes related to preeclampsia, in particular, PCOS associated with cardiovascular disease. ACOG has emphasized that the Well Woman visit should talk about heart-healthy lifestyles and reducing cardiovascular risk factors or modifying behavior where possible. And then we get back into the management of cholesterol at the bottom of this slide. So I'm going to go back to this slide for a second, and I'm going to say this: any primary care problem that you have an abnormality in, like elevated lipids, the first step is going to be counseling, and the first treatment is going to be behavioral modification. If you then are going to move on to medical therapy, we base medical therapy for elevated cholesterol on the level of risk for cardiovascular disease over the next 10 years. We don't base it on specific numbers per se, although very high numbers let me go forward on this next slide. Very high numbers, like an LDL greater than 190, is a reason for cholesterol lowering therapy, but most patients are not going to be this high. And so what we're going to have to do is use some type of risk calculator. There are a lot of different risk calculators out there that take into account risk factors and allow us to calculate this 10-year risk. And there's low, intermediate, and high risk results, basically less than 5%, 5 to 10%, and then greater than 10%. And so the bottom line is that patients in that intermediate category between 5 and 10% are the patients who usually get lipid lowering therapy. I can say that because I say usually because different organizations use different cutoffs. So if you're actually treating patients for high cholesterol, some people institute statins at 5%, some at 7.5%, and some at 10%. So again, just be aware that these are the key points: the lipid panel, the components, what are the normal results for each component in the lipid panel, the fact that it's related to cardiovascular disease, the fact that cardiovascular disease is the leading cause of death in women, the fact that any modifiable risk factor that we can address, we should be thinking about. Lipids is a modifiable risk factor. We begin with behavioral modification. We think about risk assessment for 10-year risk of cardiovascular disease using a calculator like the American College of Cardiology, American Heart Association endorsed calculators. The pooled cohort equation is one of those. We calculate the 10-year risk, and then we make a decision about instituting a statin. And then if you were going to be asked, well, let's say that for this patient, you were going to institute a statin, what statin would you start? There are multiple statins available. Usually we start with a moderate intensity statin. A good example would be atorvastatin, 10 milligrams once a day. Okay, I think that's pretty much the end of this discussion for the OBGYN boards. Anything beyond that, and it's really bonus. So I'm going to go ahead and I'm going to just stop on this slide because we're going to take a break in a minute. Before I do that, I'm going to answer the questions that we have. So let me just get access to the questions here. Can you clarify recommendations for clinical breast exam? Good question. So I want to differentiate self breast exam from clinical breast exam. So the self breast exam is a patient doing an exam on a regular basis. We used to teach patients to do it on a monthly basis, the same point in their cycle, to assess for any changes that they might bring to our attention. This is not routinely recommended anymore for average risk patients. Instead, we recommend that a patient do self-breast awareness. And this would be where they just know that if they notice something different about their body, if it persists beyond 1 month, one menstrual cycle, then they should let us know, okay? So that's self-breast awareness rather than self-breast exam. Clinical breast exam. Clinical breast exam in routine screening of average risk patients is still recommended. It has been shown in studies that clinical breast exam and screening mammography have a slightly better result than either alone. So clinical breast exam is usually done on an annual basis along with annual screening mammography. In patients who are high risk as part of enhanced screening, clinical breast exam is usually done twice a year. So hopefully that answers your question. Let me just, as I go, I need to just deal with each one. Hold on 1 second. I have another question. It's about an institution not using the ASCCP. We use our own guidelines, which are quite different, and uses something called dual screen for HPV positive. How do I approach this for the exam? This is a wonderful question. Anytime that you in your practice or your institution are doing something different than what you know is sort of the standard of care, it is a tremendous opportunity. And the reason I say that is because the examiners will likely notice it and they'll ask. I mean, so much of this exam is about psychology. On the examiner side, it's the psychology of predictable questions. We're all human beings. We see something, we want to know more, we're going to ask. On the examinee side, it's about being comfortable with ourselves and accepting the fact that there's not one size fits all, and that the most important thing is how do we enter into a discussion that puts us in our best light. When you're doing something different, if you're doing it as part of an institutional protocol or policy that's acceptable, understand a few things. They will want you to talk about the basics of the standard of care to make sure that you know what the recommendations are in general. They'll want to know what you're doing, so you need to understand it. If you just kind of say, we do something different, but you can't elaborate, that's not going to be good enough. And they prefer if you could tell them what is the rationale that your institution or practice is using to advocate for that approach. And there's usually some research or some prevailing concept that enters in, but sometimes it's about the demographics of your population. So keep that in mind. And I always think about gestational diabetes screening. It's been a controversy for forever. And of course, the ideal approach has to do with your population. But anyway, I'm not going to get into specific topics. I'm just going to say, understand the rationale for why you're doing it. I will also say one other thing. If it is being done under a research protocol, so what I was just talking about was a protocol or a policy that was just made that's basically justified by some rationale and often references. But the second thing I'm talking about is a research protocol. That's also excellent, especially if you're involved in the research. It is really great because it makes you look even that much more academic and involved in improving healthcare for people around the world over time. So if it's a research protocol, again, know what the research protocol is, how patients are selected in or out of that particular research protocol, what are the main outcome measures, these basic kind of facts about the research protocol. Again, it's a wonderful opportunity in the exam. It's not a problem. And it sounds like a daunting task to prepare for it, but it's really not, because remember, the likelihood you're going to be asked is so much higher that this is preparing for something you can expect to be asked, which is very high value. And the little bit of time you put into the background that I just gave you will pay off in spades. So I love it. Okay. Let me see where we're at. We are at 11:52, and I believe that our ExamPro admin are monitoring me to make sure I don't deviate too much from our schedule. We have answered the questions that we have. So what I'm going to recommend that we do, if they will weigh in and give me the go ahead on this, is that we will take our break now.